Hello.
Hi, Sushil. Hi, Srinivas.
Hi, Ravi. How are you?
Very good, thanks. Look, on behalf of Dr. Hansen, my co-operator, I'd like to welcome you all to North Shore Private Hospital in the heart of Sydney. And we're very grateful to the organisers for giving us this opportunity to share a very interesting live case with you. If it's okay with you, we might get started with the clinical history. Dr. Rao, our fellow, will get started and then we'll move on with discussions, if that's okay.
Thank you, Professor Bhindi. Good morning, everyone. We'd like to present the case of a 77-year-old female who presents with severe symptomatic aortic stenosis. She has a background medical history of coronary artery disease, hypertension, and a prior spinal fusion. She lives independently and is the carer for her husband and lives 4 hours away from the nearest metropolitan centre in regional New South Wales. She's a small lady and her surgical risk is low, deemed via the STS score of 3.1%. Move on to the next slide. Her investigations here show a normal full blood count as well as preserved kidney function, and her ECG demonstrates sinus rhythm with a left bundle branch block. Her echocardiogram shows preserved ejection fraction. She has a bicuspid aortic valve with severe aortic stenosis. Her mean gradient is 55 millimeters of mercury. There's no other valvular disease. The angiogram shows a focal mid-right coronary lesion of roughly 50%, and the left system shows only minor disease. Her CT TAVI demonstrates a bicuspid aortic valve. It is a Sievers 1 with fusion of the right and left coronary cusps. The annulus measures 356.8 millimeters squared, and there is no hostile or prohibitive calcium at the annulus or LVOT level. Our next slide shows that the coronary heights are adequate. The left coronary height is 12.9 millimeters and the right measures 14.4. Here we can see that the intercommissural distance is 24.4 millimeters. The implant angles are demonstrated there, and the hockey puck view shows the 3D anatomy of the aortic complex, valve complex. The iliofemoral system here demonstrates mild to moderate calcification and mild tortuosity. There is a focal narrowing in the right system and the puncture site does not seem ideal. The left is slightly larger and more suitable for delivery of TAVI. We evaluated our patient's anatomy through various bicuspid classification systems. As mentioned, she's a Sievers type 1. Via the Bavard classification, she has a flared anatomy, and the Mackay-Yoon classification shows or suggests that she has no extensive calcification in her raphe or in her leaflets. At this point, I'll hand it back over to Professor Bhindi and Dr. Hansen.
Thank you very much, Dr. Rao. So to summarise, this is a 76-year-old lady with bicuspid severe symptomatic aortic stenosis. She's low surgical risk and has very high gradients to start. From our perspective, there are a number of considerations. First is how do we manage this lady with bicuspid anatomy, small annulus with no aortopathy? Second, what are the measures we do to optimise her index valve implantation? And third, how do we optimise or future-proof this intervention for the future in terms of lifetime planning? I'll hand back to you guys in the panel for discussion, and then when you're ready, we'll let you know where we're up to and get moving with the case.
Great. That's a sort of a great overview and very nice imaging. Maybe some comments from the panelists. And so you have a bicuspid valve, 77-year-old woman. STS, I think, was around 3, if I recall. You know, what are the considerations? I don't know. Samir, I see you have a mic in your hand. What are your considerations when you look at a patient like this in Cleveland?
So the main question is that how long the patient is going to live. So it is likely that this patient will live at least 20 more years from now. And if you are going to do a TAVI, the question would be that whether you are going to be able to do a next valve easily enough or not, because there are going to be at least 2 valves in her lifetime that you should potentially plan. The anatomy is such that I think that you can put an S3 valve, and it could be a 23 millimeter valve, and then in the future you can potentially put a self-expanding valve in the S3. But the question is that I was not 100% sure about the STJ height. that what was the STJ height from the annulus. So if the annulus height is such that you will not be able to put a valve in valve, I would personally consider for surgery, because this is a low risk patient for surgery, and we should do surgery first, and then we'll be set up for valve in valve in the future.
So I guess that was one of your comments, Ravi. You were talking about you raised the issue of, you used the term future proof, or how are you going to manage this patient? What was your team's thought process? Samir is saying, she's young, relatively young. I guess it's all relative now, 77. But what is your strategy in managing this patient?
Look, we agree entirely with all the comments of Samir, and we did measure the STJ height, thinking about future planning. Our approach after discussion with her and the heart team was to offer a TAVI. We were going to use an S3 balloon expandable valve. The STJ height is such that if we put a self-expanding valve in now, the leaflet tips would go above the STJ, and we've simulated a VTA of around 2 millimeters, which potentially risks under-sequestration for a future valve-in-valve procedure. If we put a balloon expandable valve in, we have adequate clearance to the STJ for a future self-expanding in balloon expandable valve. There's no hostile calcific RAFI or annular features that would mean that we wouldn't get an optimal result with TAVI at this juncture. The BSA isn't high, so we don't anticipate any significant patient prosthesis mismatch, which is an important consideration. And we agree that if there was an aortopathy or any other feature, such as a shallow STJ, we would clearly offer her surgery as the preferred option.
So it's interesting. So, just to be clear, though, from an acute procedural risk perspective, you would feel comfortable with any valve. Your valve choice now is more about what happens when this valve fails. Which valve now, the way your thought process, which valve now gives me the best option for putting a valve in valve later?
Well, that's one consideration. The second consideration is that she is from a regional centre. In fact, she's from the regional centre where I grew up. And that's sort of a number of hours from a metropolitan hospital. And so coronary access, given that she's got moderate coronary disease, is an issue. It's not an absolute issue, but it is an issue if she was to require interventions. It may be a challenge in a non-metropolitan centre. Accessing a coronary arteries with a high valve was another factor that pushed us towards using this valve.
Right. I think you talked about the small annulus and self-expanding versus balloon expandable. Any comments from any of the panelists? Or, I think there's not, there's no one right thing that you make a decision on. This is a small lady with a small BSA, so a 23 sapien would give perfect hemodynamic results versus an Evolute giving the same hemodynamic results. And so I think you have to take it in the context of the patient, but coronary access, pacemaker risk, valve in valve, and I think this is the way that TAVR has evolved. And a 90-year-old woman, you might think differently than now, but I don't want to hold you up. If you want to show us where you're at and maybe move forward.
Perfect. So we'll show you what we do. We've approaching a minimalist approach. She's under conscious sedation. We've got a right radial 6-French sheath in with a pigtail already in the non-coronary leaflet. We've got a venous sheath in, and we'll be pacing over the wire today, and we've got a wire in the 6-French right femoral vein with a crocodile clip for pacing on the wire. We've got the E-sheath in with one ProGlide, and our intention is to deploy one angioseal at the end of the case. So without further ado, I'll get Peter to move ahead, and we've got the JR4 to cross, and we're ready to sort of do our crossing. And I just guess this is an opportunity to discuss with the panel how they cross the aortic valve and bicuspid anatomy. What are the challenges or tips and tricks they have?
Dr. Gokul, any
one question I wanted
tips and tricks in crossing bicuspids? Was preferred strategy, preferred catheters? Any?
Sushil,
can we get another microphone over here, please?
Sushil, one question is about the use of brain protection in this type of patient.
Yeah. So the question here was embolic protection or sentinel use in cases like this, right? What is the use in Australia? Is embolic protection used routinely, rarely, or case by
Look, it's
case?
used. Look, I think it's a good question. We used to use it before the trial, the pivotal trial came out, and we're awaiting the UK data. At the moment, we're using it in selected cases. If we were doing leaflet modification, we might consider using it, but we don't use it routinely. I'd be interested to see what you guys do in India and in the US, what your approach is, whether you've got an ability to work out who might benefit.
So, so you're saying Samir is responsible for you not using the embolic protection. So maybe I'll let him answer since he's the one responsible.
So no, first of all, I think for a bicuspid valve, there is enough literature to say that the stroke risk is a little bit higher, especially if you are low risk. And we would use it for these purposes. The protected TAVI trial was negative in the primary endpoint, but since then there is so much literature to say that there is some benefit in preventing the disabling stroke. So I would personally consider it in these patients to use, especially if they are low risk.
Yeah, no, we're not, we don't routinely use it, but your point's well taken, Samir, and I was with Dan Blackman a few weeks ago, and he enrolled 6 or 7 for the UK study while I was there, so and he seems to think that there may be a benefit, so it'll be interesting. I just want to show our hemodynamics here. Peter crossed with a JR4 and a standard straight wire, and you can see that there's a fair gradient there. And when we do these routine hemodynamics beforehand, we look at the diastolic separation just so that when we deploy the valve, we've got an idea as to where we've ended. And without further ado, we'll keep moving on here. We'll use a safari wire, just an extra small safari wire, and we'll just deploy that directly through the JR4. We don't normally use an exchange length wire unless we get into trouble as we extrude the wire, but some people at this point would use a double length standard J wire to try and prevent entanglement. But we've found that if we've used a JR4, we probably will be okay, and I think here we've got a reasonable position of the wire. Now, would people predilate in this situation? We'd just be interested to get the panelists' thoughts on how they would approach this sort of case. Predilatation or no predilatation?
Ravi,
What are your thoughts?
Ravi, can you hear me? Anand here.
Yes. Yes, hi Anna.
Nice to see you, man. Good case.
Yeah.
I'll probably, before mentioning about the predilatation, I want to put a spin on that from the Indian perspective. As you said, small annulus, recent evidence, all those things with this smart trial, the higher usage of self-expanding platforms, especially in India. This case could be done by both platforms. If it'll be a 23, I think.
Can we turn that mic volume up a little bit?
Can you hear?
Yeah, now it's good.
Yep.
So I think I was going to put a small spin in this because with the current sort of smart trial evidence, all those things, and the amount of bicuspids we have in India, which is more than 50% plus, obviously, and again, small annulus more than 50% plus.
Injection.
It could be used with both platforms. If I use, I'd probably using a 29 evolute versus a 23 balloon. With regard to predilatation, this particular valve I'll not predilate because there's not much calcium there. I'll probably go and put the valve. But again, the predilatation allows you so that you don't post-dilate. That's the thing.
I mean, in general, we're pretty aggressive about pre-dilating bicuspids in our center, but this is not as calcified. And I think one of the important points is, in India, there's a lot of bicuspid anatomy. It's 40 to 50% of the cases, I understand. But even that is all heterogeneous. Some are this like non-calcified raphe, but there are a lot that are type 1 calcified raphe, right? And so those are behave very differently, and that's what your point was, that in those especially you want to aggressively predilate. What size balloon would you take if you're predilating? What would people use? Ravi, do you have a plan?
What was the balloon that, Ravi?
We used a 20 millimeter balloon. We don't. We felt in this case we should just demonstrate where there's a hinge point. Have a look at the coronaries. We don't routinely predilate unless there's calcium. In this case, we just wanted to ensure the pacing was adequate, that we'd get a good space and an easy cross because of the because of the bicuspid nature of the valve. And just to your point, I think you raised a very good point. We carefully simulated a evolute in this anatomy, and the problem was that if we had put an evolute R in, the second valve would have been very, very tricky because we would risk sequestering the sinus or making coronary access impossible for the next intervention. But I think your points are very fair.
It's also important, like if you're simulating a second valve with an Evolut R, the sapien is going to be very undersized because you're talking about in a 360 area where the sapien is okay now, but then when you put an R and you take another millimeter around with the frame, your sapien becomes very underexpanded as well. So the sapien post and Evolut, sometimes in these smaller annuli, is different. Go ahead, Ajay, sorry.
No, I mean, the only thing I was going to say is, the comments about the SMART trial are important, but remember, it's a hemodynamic-based endpoint, and in this patient, you're making a clinical decision of long-term, not only the durability of the valve, but what's going to happen with the second procedure. And so I think that's the challenge with a trial that has a one-year endpoint. That trial is going to be a great trial at 5 years to see if there are any clinical differences, but in the absence of seeing that right now, these other extenuating factors, in my mind, would seem to trump that potential hemodynamic benefit,
Right.
which is potential at this point.
Yeah, I think that's an important point. You need to, you take, but already made the point, take everything in context. Pacing on the wire, it's becoming increasingly used. Now, Ravi, when you do an Evolut, do you do the same?
We do the same thing. We do the same thing, Sushil. We routinely pace on the wire. Sometimes we have problems, 1 or 2% of the time, and then we put a venous pacing wire in. We find it more reliable. I remember we did a live case with John Webb a few years ago, and he was very anxious. But I managed to convince him to do LV pacing. So I think it works. I don't know what the usage in India is of LV pacing. It avoids the complications of an RV.
It's far less. I was going to ask you, this is left bundle, so you're fine. In your right bundle cases, what do you do?
We still pace on the LV wire. We have a venous sheath in. The pacemaker rates there would be 40%. So we obviously address it at the time.
Or do you keep a venous sheath?
We keep a venous sheath in for right bundle. Yeah. So with this, so we showed an annulus of about 355. The CT scan wasn't that great. There was some shadowing. So the estimates were between 355 and 370. And I just wondered what people would do with their Edwards balloon. Would they deploy this at nominal, or would they take out some fluid from the indiflator?
Samir or Dr. Roth, would you guys, how would you, so do you underfill the balloon? Do you go based on how it feels at the time, how it looks, whether it's waste? What is your strategy?
So usually for this one, I think at 350 or 360, I would say just go nominal and go to 6 atmospheres. So we measure the atmospheres and we say that we go to 6 atmospheres. But if you wanted to, you could take 1 cc out and go all the way and then post-dilate if necessary.
Yeah.
With a
So
relatively
looking at this arch here, we did think about the Protect TAVI when we were putting the valve. So we're being very careful here, and I'm pulling on the wire as Peter's pushing the valve in, and we'll go to the 3 cusp view. So we've taken a mill out. We don't routinely use the indiflator method unless we're fracking. I know there's some data on that, but we haven't routinely started.
And the left leaflet is a little longer, huh? So this is also bothered me a little bit. But
Yeah, and interestingly, from a lifetime planning point of view, the left coronary doesn't come off at the center of the left sinus. And so for orientation, commissure alignment wouldn't really help in terms of future planning anyway. So that was another reason why we thought commissure alignment wasn't necessarily going to be helpful in this case. It's more about the coronary alignment here. So Peter's going to cross here. We've pre-dilated and,
with the future kind of TAV you mentioned, the depth, are you going to go for around 3 or higher being a bicuspid? What's your depth going to be, right?
I'd be interested to see what everyone thinks. We're now in a position to deploy, and this is why we've got you guys giving us advice. We've got, the A-League of balloon expandable valves on the panel, so I'd be interested to get your views on how high and how deep you think we should be here. We're undersized by 1 mil.
I mean, I generally I position the top where I want it right at the left coronary in a case like this. I don't want it to go above the SDJ. I don't want to injure the SDJ, and the top is not going to move, so you sort of use the top of the valve.
So you probably keep a little bit lower, right? Because usually with the bicuspids I go around sort of 1 but in this case I probably go around 3 millimeters at least.
Okay, all right. Yeah. I think so. Well, we might just take a pacing, we might just do a test here, Peter, and just see where we're up to before we start pacing. I'll just do a test here. What do you guys think? I haven't started pacing there, but we'll just fluoro grab that and just show the panel before we, oh, it's a bit of a long grab there. We'll just do that again. You guys potentially happy with this height, or you think that's too low?
I think too low in my opinion. But
Yeah, I think in systole it comes up, but you still have a lot of room in the left corner, so you might be able to come a little higher.
Yeah, we might just pull that up a little bit with the knob, and we might just be ready to go here. So if you're okay with you guys, we'll do an injection, and if we're happy, and if you guys are happy, we'll deploy. We can start pacing now, and we're ready for an injection now, please. Inject. Happy there?
Yeah, looks
Looks
good.
good.
Okay, so.
Yeah, that's great.
Okay. And we normally, we usually jail our pigtail. I don't know whether that's just something everyone else does, but we've never had problems with it.
We always pull it because I feel uncomfortable that when you're pulling it, that the embolic. I know everyone's done it, like whether you liberate embolic debris, especially in an NFA sinus.
Yeah.
But I don't think there's any right answer. I think half the people do one and half the people do the other. I
Yeah.
think.
Yeah.
we use a straight
We
flush-
might just do an aortogram
a
here.
straight
so-
flush catheter, so you can
Yeah.
leave it and it comes out easier. So instead of a pigtail,
You do a multi or something?
there is a straight flush catheter with multiple holes
Okay.
and straight rather than a pigtail.
Nice.
So that's what we use.
Inject. All right, so we've got, I think it looks pretty good. What we'll do is we'll take the system out and we'll do some hemodynamics, and then we'll get some echo images for you guys. Were you happy with that height in the end, guys? Samir, I really enjoyed your loosened line paper, and we were using loosened line for a while in the two cusp, but we thought for the bicuspid it might just be easier to show a more, given the anatomy was a bit ambiguous on CT, we wanted to keep it safe, and we've just shown a three cusp view. Do you want to talk a bit about your loosened line method for the audience?
Yeah, so usually what we do is we just take it to the areocaudal view and take out the parallax, and then look for the loosened line and say that if we put it at where we want to put it on the non-coronary cusp. So this is a simple way of deploying it high. But again, the height depends on what you want to do ultimately. I think in this patient, it is good to have an LAO aortogram, so that in the future, whenever they need a valve-in-valve or something, if you want to look at it, you can be a little bit more certain about the coronaries. But it looks very good.
I think that looks great. And one thing you see though, and people
Okay,
are
excellent.
talking more and more about this. There's, the sapien is asymmetric, and the question is, there's this whole discussion about, do you just post-dilate routinely, like a coronary stent? We always leave it up for 20, 30 seconds because you got to expand into the calcium. Here,
Yes, if you
sometimes
can
we get
echo,
nervous
yeah.
with the no blood pressure, and you go up and you come down, and you don't deliver the true force. So whether you go up and do it again, oftentimes if you post-dilate these, they become more symmetric because it engaged. And I don't know if that makes a difference or not. And the engineers from Edwards I've asked, and they haven't said whether it makes a difference, but it looks longer on one side than the other, and that is because the stent has not fully expanded, and this is underfilled. And so this question of just post-dilating here for the geometry, would anybody consider that?
So we just looked at our data for the asymmetry to say that whether they have a long-term implication, and we did not find anything. So we looked at the LAO and RAO view, and it's not yet published, but at least I couldn't find anything in terms of halt or in terms
We can
of
show echo, please,
gradients
guys,
or
for
long-term
India.
durability. So I don't know, it may cause pacemaker need higher
Steve?
if you keep post-dilating it.
We haven't done that routinely as well, but I've seen some patients with
Get
some
echo
component
on
of
the image.
recoil and PVL later. So I've become more deliberate about at least trying to stay up for 3 to 5 seconds. The hypotension will recover in general. You don't need to wait too long to start going up, but give it time and stay up or post-dilate. Juan, you had a point?
Look, from the clinical point of view, I mean, the data has to speak, by itself, right?
Yeah.
But from the biomedical, mechanical point of view, to actually end up with a, circular valve is going to actually improve the chances of leaflet longevity. And
All
you
right.
see that actually on benchtop models and everything, but it's to be proven with data, right?
So Sushil, I might just get Dr. Chung, one of our echo colleagues, to show you the echo images. If we could get echo on the screen, Chris, and if you wouldn't mind just talking through anything of interest that
Yes,
might...
Ravi. Yes. Just a long axis view first. We had the pictures there in a moment ago, and it looks great. The depth looks excellent. I couldn't see any AR in this view before, and again, that applies. There's no effusion. There's no obvious hematoma to see. So I've done the short axis before, but I'll quickly go to the apical window as well. The parasols are not as good as the apical windows are. So at a quick glance here,
And Chris would be very interested in getting a gradient because we've got no gradient invasively or minimal gradient invasively.
so I'll go to the apical window now and have a look there. Just start here. Put a little bit more gel on it.
While Dr. Chung is getting images, we might just show the inflation again. Does anybody, Sushil, I take your point about post-dilatation. Does anybody feel strongly about the need for us to post-dilate? We're not inclined to, but if we can show the inflation, Chris.
Ravi, that looks a surgical-like result, and you have no AR, no gradient.
Yeah.
A fluoroscopic appearance should not fool us. I'll probably walk away from that. It looks fantastic. Congratulations.
I agree. Our practice is not to post-dilate because you risk injury. You have a small annulus, small root. You have no AR. You don't see invasive gradient. We'll see what the echo gradient is.
So we'll get the echo gradients up, please, guys, or the echo images again for India. And
Yeah, it looks
The
low.
LVOT, that's just the LVOT bit. I'll just show you the valve gradients.
Chris is just going to show you the gradients. I can't actually see the gradients, but you guys can probably in India.
.5 maybe?
So it's a little bit, yes. So we'll take that one. So the velocity is 2.6, 2.7, which equates to a peak of 29. If I go and trace the mean,
I think again, gradients are hyperdynamic LV, flow dependent
Indeed,
measures, so
indeed.
looking at DVI as well. So this is obviously a little bit higher than we would expect, or in this patient. But do you think it's at the valve, or do we think it's volume or flow? And looking at the DVI, does it make sense? I think those are all important considerations, and I would look at that before making any
Absolutely.
decisions.
No, we're very happy. Invasively, we've got no gradient. We're really pleased with that result. And I think it's not, and I think this is the whole point of this small annulus challenges we find, but it's good to get, she is a bit hyperdynamic on the echo. Now, what I'm going to do, if we have time, and I guess the question is, how do you guys close? And we'll give a bit of protamine here, and then we'll, can we get the camera back up there? And we're going to close on the ProGlide and then put an angiosealant. Is that how everyone back there closes, or is there variation? 2 Pro styles?
I do 2 ProGlides. What does the audience do?
I like your way of doing one ProGlide and one angiosil if necessary.
Here, obviously, if the vessel size is more than 6.5, I tend to use 2 ProGlides. But we have a lot of small vessels like 5, borderline 5, and I use 1 ProGlide and just one angio. Just reduces
Yeah.
the stenosis.
Yeah, and do people routinely take a picture of the groin before closing, or do they just, if there's been no problems, do you just close without looking?
I always do a final angio after closure because you sometimes you get surprised later, and you don't want to be surprised in the middle of the night.
Yeah.
Even if I'm using 2 ProGlides, I tend to put the micropuncture sheet back and just take one picture. No major ooze, then just bring everything
Yeah.
out.
Excellent. And protamine or no protamine?
Half dose protamine, halfway.
Yeah.
We got half dose protamine. Yeah, that's probably what we do majority of the time.
Yeah, and that's what we've done here, and we've just put 1 Pro style, and you can have a look in the groins, looking pretty good there. So look, that's it from us, I guess. And I just, I think happy to take any questions or discussions before I just acknowledge my team here.
That's wonderful. It's a great demonstration, great case. So you'll get you'll get an echo pre-discharge, when she's a little bit more volume, sort of normalized.
Yeah, absolutely. We'll get another echo. We'll get an echo later today after she's been volume repleted, and my expectation she'll go home tomorrow morning.
So she has a left bundle, or do you send people out on? In the U.S., we've been using a lot of MCOT. We discharge the next day, patients with a PR prolongation, left bundle, but no clear indication for pacing, that we put them on real-time monitors to see if there's anything happening. Do you do that? Do you monitor them any longer when they have conduction abnormalities?
No, for left bundle, so we're conducting a day-stay protocol. She wouldn't qualify because she's got left bundle branch block. We've just completed, and Dr. Rao will hopefully present at London Valves on our Conduct TAVI study, where we did EP studies before and after every TAVI, and you put loop recorders in everyone. If there's no change in QRS dimensions pre and post left bundle, we don't do anything special for them. Right bundle is a slightly different beast, as you all know. But if the QRS complex, which here has largely been unchanged, we're not going to do any prolonged monitoring.
Great. Well, thank you so much for a great demonstration of how to treat a bicuspid with a balloon expandable, sort of the minimalist but thoughtful approach. Great pre-procedural planning, addressing all the issues from conduction to pacing, how you manage the groin, all remarkably done by you, Chris, the rest of your team. I want to thank you for joining us at TCT Plus India. Thank you again.
Thank you, everyone.